Next slide, please. So, these are my disclosures on the end and the disclosures of the two speakers. And I think I have to go there. Huh? And we have two distinguished speakers and experts in the field of respiratory medicine, Professor Peter Howard and Professor Ian Pavord. And I would like to introduce first our first professor, Peter Howard. He is Professor Emeritus in Allergy and Respiratory Medicine at the University of Southampton, where he has ongoing research related to severe asthma. Professor Howard has published over 300 peer-reviewed papers with an H index of 100 and has contributed to national, European and international guidelines on the management of rhinitis and asthma. He has been involved in collaborative programs focusing on severe asthma, like the European Network of Understanding Mechanisms of Severe Asthma, like the longitudinal assessment of clinical course and biomarkers in severe chronic airway disease, and in the program Unbiased Biomarkers for the Prediction of the Respiratory Disease Outcomes, and of course in the Global Allergy and Asthma European Network. I will introduce later the other speaker, Professor Ian Pavord, because he will connect with us. And this is our agenda. After a very short introduction, we will have the talk from Professor Peter Howard about the eosinophils and interleukin-5 in severe eosinophilic asthma and comorbid nasal polyposis. And then we will have the talk from Ian Pavord, targeted therapy with Nepalism in patients with severe eosinophilic asthma and comorbid nasal polyps. And then we will have a discussion, and the topic of our discussion will be the relevance of upper and lower airway disease to patient outcomes. And in the end, Professor Howard will give us the closing remarks. So, ladies and gentlemen, it is fact that the lower airways and the upper airways form a unified functional unit, and our patients have the same clinical features, the same symptomatology, and we know that in patients with severe eosinophilic asthma very often have also comorbid nasal polyposis. So if we go to the pathomechanism, we will see that this is an eosinophilic inflammation, a type 2 inflammation in where interleukin-5 plays an important role. So the question is, if our patients share the same pathomechanism and if they share the same symptomatology and the same clinical features, then the upper and lower airways may benefit also from a unified treatment approach. A few words about the eosinophils and about interleukin-5. You know that interleukin-5 is an important mediator responsible for the recruitment of the eosinophils, and the eosinophils are a marker of the interleukin-5 inflammatory biology. And we know that if we can block and inactivate the function of interleukin-5, and this is possible with Nepalism, which is a humanized monoclonal antibody, then we will improve the clinical course of our patients. We will improve the exacerbations of the patients with bronchial asthma, and we will improve the quality of life of our patients. I would like to note that Nepalism is not approved for the patients with chronic rhinosinusitis with nasal polyps in the European Union. So, I will give the word to the first speaker, Professor Peter Howard.
Yes, thank you for that excellent introduction, and I also extend my welcome to all of you who are here today, either in person or virtually. we've recognized for many, many years that when you look at the histology of the airways, that in the lower airways in asthma there is a prominent eosinophilic inflammation. And here we have a GMA-embedded bronchial biopsy stained with EG2, highlighting the eosinophils in red. And we're going to talk today about the upper and lower airways, and I'm going to start with the lower airways before moving on to look at the similarities that we experience in the upper airways. Now, those eosinophils are generated in the bone marrow, and an important systemic signal that drives the maturation of eosinophils is interleukin-4, a key cytokine from the type 2 inflammatory process. And we recognize that within tissue sites that might come from Th2 cells, but often, importantly, in disease that's more difficult to manage, from the innate lymphocyte 2 cells. And there is a direct relationship between interleukin-5 and the eosinophils within the circulation. And they are then recruited to sites of that type 2 inflammatory disease process. And we recognize that eosinophils are predominantly a tissue resident cell, that their life in the circulation is relatively short, less than 24 hours, but they may live for several weeks within tissue, and depending upon the signals they receive in that local environment, we recognize that eosinophils are a tissue-damaging cell, and that the release of granule proteins, particularly the cytotoxic secretory products such as major basic protein, eosinophil cationic protein, eosinophil peroxidase, can be implicated in that tissue damage. And within the lower airways, one of the major sites of tissue damage is the airway epithelium. Eosinophils, when they're recruited and release those major basic proteins, damage tight junctions, loosen the airway epithelial cells. And in asthma, one can see clumps of epithelial cells appearing in sputum. And that generates a repair response. As the body attempts to repair the barrier function, and part of that repair response is signaling to the mesenchyme with growth factors such as transforming growth factor beta, which converts fibroblasts to myofibroblasts and increases the amount of collagen generation. And eosinophils themselves can directly influence that process, because they also can secrete TGF-beta and other growth factors such as osteopontin and fibroblast growth factor. This behavior of eosinophils in changing these mesenchyme structure is a normal repair response, but is exaggerated in these disease states because of the excessive eosinophilic inflammation. And we see on the right-hand side of this panel a bronchial biopsy study which measured that collagen thickness within the airways, and you can see that it was noticeably increased in those with severe eosinophilic asthma, but not in those with severe asthma that were non-eosinophilic. And that structural remodeling of the airways has functional consequences. In the lower airways, it leads to thickening of the airways, which you can see in CT scans when looking at the wall area of the proximal airways. And the thicker the airways, the worse the lung function. That remodeling prevents the bronchodilatation that would normally happen when you give a beta agonist. And so with progressive remodeling, you see poorer lung function and less reversibility. And as we move to a severe asthma population in a cross-sectional study and compare those individuals with severe asthma who've ended up with irreversible airways disease compared to a group of patients attending the same severe asthma clinic whose lung function is preserved, one can see that when one looks at the various characterization factors that are associated with having that impaired phenotype, is a high peripheral blood eosinophil level. With an odds ratio, if you've got blood eosinophils of 400 or more, of having 4 times more likely falling into that group. And similarly, if you've got those structural changes on CT scan with bronchial thickening, you're much more likely to fall into that group. We also recognize that in addition to remodeling, eosinophils can affect function through mucus production. This was a study that used CT scan imaging to measure mucus plugs within the airways. And they gave individuals a mucus score depending upon the extent of that mucus plugging, and then they looked at the characteristics of the patients. And what they found was that those with high sputum eosinophils were the group with a high mucus score. And they went on in this study to understand the mechanisms of that and identified that that mucus score was also linked to high levels of eosinophil peroxidase, one of those granule proteins from the eosinophils. And eosinophil peroxidase causes cross-linking of the cysteine bonds in mucus and changes the characteristic behavior of it. So instead of being a slimy, easily expectorated mucus, that mucus becomes very sticky and thick and blocks the airways and is much more difficult to expectorate. And so the presence of eosinophils is a crucial factor in changing the behavior of that mucus. And what the study found was that those with the high eosinophils and the high mucus score had the poorest lung function. And that lung function was resistant to standard therapies. So it didn't improve with beta agonists, bronchodilators. It didn't improve when they gave them a depot injection of steroids. And so we have a process that, once it happens, is difficult to symptomatically reverse or physiologically reverse. And so really, when we're thinking about eosinophilic diseases, we're thinking about prevention, preventing that eosinophilic inflammation, preventing these episodes happening. And that's particularly true when you think about severe exacerbations. The eosinophils adversely interact with the airway epithelium in another way. When we all are exposed to viruses, not coronavirus, but to rhinoviruses, the body mounts an immune response which is directly driven by the epithelium recognizing that virus through a pattern recognition receptor called toll receptor 7. And when the virus interacts with toll receptor 7, it generates interferon, and that interferon is part of the innate immune response. It leads to apoptosis of those infected epithelial cells, which are shed and coughed up. What's been identified previously in asthma, particularly severe asthma, is that there is a deficient interferon response. And studies in Newcastle, Australia, identified with data shown on this slide that the higher the level of sputum eosinophils you have in the right-hand graph, the lower the level of toll receptor 7 expression on the epithelial cells. So the presence of eosinophilic inflammation prevents you mounting your normal innate immune response, which will clear the rhinovirus. So that rhinovirus persists, infects other cells, and that underlies disease exacerbation. And one can see that direct link to exacerbations in asthma from this study carried out in the United Kingdom in primary care, where a very large number of patients had records of their blood eosinophil levels. And the researchers then looked what happened to them in the year after that measurement was made. And what they identified on the left-hand panel is that the higher the blood eosinophils, the greater the likelihood of that individual having a severe disease exacerbation that required oral corticosteroids. So we see that blood eosinophils are a predictive biomarker of future risk. On the right-hand panel, they looked at the relationship between blood eosinophils and what happened to that individual as far as their asthma control on a daily basis was concerned. And it also identified that the higher your eosinophils, the worse the daily asthma control was. So we recognize in the lower airways that eosinophils are very central to the pathophysiology of severe asthma, contributing to epithelial damage, repair responses, remodeling, excessive mucus production, and eosinophils within the airways are a major source of interleukin-13, which drives that mucus, and then eosinophil products such as EPO will change the character of it. And other products from eosinophils, such as leukotrienes, are involved in smooth muscle behavior, and we also recognize an important neural interaction with the eosinophils. Now, if we move to the upper airways in nasal polyps, we see a very similar histology, even a more intense histology. For many years, pathologists have looked at polyps and said this is an allergic polyp. And what they're meaning by that is that there is eosinophilic inflammation in the polyp. We now recognize that it's probably non-allergic factors that are driving it, but the presence of eosinophilic inflammation is prominent. And we recognize that there is a common association between lower airways disease and upper airways disease. There is a large prospective international study of Nepalism in severe eosinophilic asthma called Reality A. It's got over 800 patients in it, and an abstract presented when there were 700 patients identified that 40% of those patients with severe asthma had nasal polyps. So we can see how common the disease is in patients with severe asthma. And on the right-hand side, I've pulled out characterization data from a number of severe asthma registries, looking at how common upper airways is chronic rhinosinusitis. And you can see in the different cohorts it varies from just under 40% to the mid 70%. If we turn that upside down and say, well, how common is asthma in patients with chronic rhinosinusitis, we see also an association. I've got one study here that I'm showing, but just to illustrate that, small study of 23 patients, of which 9 had asthma. So a little over 40%. And I would say that that's probably a fairly reflective figure for how common asthma is in patients with nasal polyps. And in a group without polyps, with 18, there was only 1 patient with asthma. And in this study, they found that 90% of polyps were eosinophilic, and that those polyps had high levels of interleukin-5. And as I mentioned, interleukin-5 is a key signaling molecule to the bone marrow to generate eosinophils. And so when we look at data from the placebo-controlled studies with mepolizumab in severe eosinophilic asthma and divide those patients up into those with severe eosinophilic asthma alone and severe eosinophilic asthma with nasal polyps or a history of nasal polyps, and look at the blood eosinophil levels, as in the highlighted in red at the bottom, we see the group, whether it be in the placebo-treated patients or the mepolizumab-treated patients, from data that's combined from 2 studies, the Musker and Mensa studies, we see that those that had disease at both sites, severe eosinophilic asthma and nasal polyps, have higher levels of circulating blood eosinophils than those individuals with severe eosinophilic asthma alone. So here we have potentially a dual IL-5 drive to the bone marrow from both the upper and lower airways, increasing eosinophils within the circulation. And when those eosinophils are recruited to the tissue sites within the upper airways, we recognize that those basic proteins I've talked about will also be tissue damaging at that site. That all the basic proteins, major basic protein, eosinophil peroxidase, eosinophil cationic protein, eosinophil-derived neurotoxin, have been shown to be significantly elevated in nasal polyps compared to blood. And there are relationships between the level of disease severity. And we recognize that probably there is a very common pathophysiology between what is happening in severe eosinophilic asthma and also what is happening in another type 2 condition in nasal polyps. That there is damage to the epithelium. And we recognize a number of factors that may arise from that point of view, but certainly in nasal polyps, an abnormal microbiome and Staph aureus interactions have been implicated in the disease. And this damage to the epithelium will drive an immune response. And we focused very much in the past on the Th2 profile, which is the allergen-driven pathway. But we know that that normally is quite a steroid-responsive pathway. And increasingly we appreciate the non-allergen-driven pathway through ILC2 cells that generate interleukin-5 and interleukin-13, are key processes, and that IL-5 will drive that eosinophilic process, as I've shown you. IL-4 and IL-13 will drive IgE-mediated responses, and we know increased IgE levels are present in nasal polyps, and the link with Staph aureus enterotoxin IgE. But very recently, Professor Laidlaw from US has identified that there are IL-5 receptors on B cells and committed plasma cells within nasal tissue, which is opening up the avenue that IL-5 may also be important in driving that IgE-mediated response. And the tissue damage leads to repair response, and as within the lower airways, that we see more fibrin deposition, collagen deposition, and polyp growth. And a recent publication from Claire Hopkins looking at the dupilumab clinical trials has looked at baseline characteristics and what it is that is most linked to those patients who have a history of recurrent need for surgery. And in this study, they looked at blood eosinophils, looked at total IgE, looked at serum periostin, which is a marker of IL-13 biology, and TARC, which is a marker of Th2 biology. And when you look at the overall significance, you can see it was the presence of blood eosinophils that stood out as being the biomarker that best predicted or was most strongly associated with the history of recurrent surgery for polyps. Total IgE was significant, but perhaps unusually, if we look at the figures, you can see the levels are higher in those individuals who did not have surgery compared to those that had multiple surgeries. So the significance was that you had lower levels if you were going on to have recurrent surgery, and the TARC was not significant. So just in summary, before we move on to hear from Professor Pavord about clinical therapeutic interactions and outcomes, I'd just say that eosinophilic inflammation is a common feature of asthma and nasal polyps, and that these conditions commonly coexist. That I've been able to show you that eosinophil presence and activation are linked to disease severity in asthma and in nasal polyps, and that the evidence suggests that the eosinophilic tendency is a risk factor for nasal polyp recurrence after surgery. What I've also shown you is how IL-5 is a key cytokine in this process, being central to driving that eosinophil response within the bone marrow. But that research, which is still at a fairly immature stage of our knowledge, suggests that IL-5 may be having a much broader influence on tissue biology other than just being a systemic driver to the bone marrow. So thank you for listening, and happy to pass on to my co-speaker now.
So the next distinguished speaker and expert in the field of respiratory medicine, as I said, is Professor Ian Pavord. I will introduce him. He has also an unbelievable CV like Professor Peter Howard. Professor Pavord is honorary consultant and physician. Can you hear us, Professor Pavord?
Yes, I can, yes.
Perfect.
Delighted to be with you.
Perfect. It's nice to have you with us. So Professor Pavord is honorary consultant physician at the Oxford University Hospitals. He is a member of the congregation at the University of Oxford and a professional fellow of the St. Edmund Hall. He served as a consultant physician from 1995 to 2013 and a honorary professor of medicine from 2005 to 2013 at the Institute of Lung Health, Glenfield Hospital, University Hospitals of Leicester. Professor Pavord has selected a National Institute for Health Research Senior Investigator in 2011 and 2014, an inaugural Fellow of the European Respiratory Society, ERS, in 2014, and a Fellow of the Academy of Medical Science in 2015. With his research interest focused on the clinical aspects of inflammatory airway diseases, Professor Pavord has pioneered the use of non-invasive measures of airway inflammation in the assessment of these conditions. He has identified several clinical important phenotypes and biomarkers of inflammatory airway disease and has played a lead role in the development of 3 of the most promising new treatments for severe airway disease. Professor Pavord is the author of more than 480 publications and has an H index of 111, making him the second most cited asthma researcher worldwide. He delivered the Carnant Lecture at 2004 in the ERS meeting, was awarded the 2016 ERS Gold Medal for his research, and chaired the 2017 Lancet Commission on Asthma. We are very proud to have you in this meeting, Professor. So, please give us your talk. Thank you very much.
Thank you, Yanis, and thank you to GSK and the ERS for giving me this opportunity to talk about targeted therapy with Nepalism in patients with severe eosinophilic asthma and comorbid nasal polyps. And this follows very nicely from Peter's talk, and Peter suggested a number of mechanisms whereby the eosinophil might alter airway function and cause clinical problems. And we have an ideal opportunity to investigate those mechanisms because we can now block IL-5 with a biologic treatment and create IL-5 and eosinophil knockout humans. So what I'm going to do is talk about the consequences of doing that in patients with these common lower and upper airway problems. Next slide. So Nepalism reduces eosinophil levels by inhibiting the IL-5 receptor signaling axis and by interacting with the cytokine itself, preventing it binding to the dimeric receptor. And in so doing, preventing eosinophil growth, differentiation, recruitment, activation, and survival. And you can see in the bottom right of this slide the consequences of Nepalism treatment on the peripheral blood eosinophil count, with between a 5- and 6-fold reduction in blood eosinophil levels, typically to a level below 50 cells per microliter. So a really very large impact on circulating eosinophils. Next slide. I'm going to talk about clinical trials, starting with the phase 2b DREAM study, which was a placebo-controlled, randomized controlled trial of just over 600 patients with severe eosinophilic asthma, where 3 doses of mepolizumab were compared with placebo. We'll then move on to the phase 3 MENSA study, which was a 32-week study looking at 2 doses, so the 75 milligram intravenously, but also 100 milligrams subcutaneous, again in a placebo-controlled study. And finally, we'll look at a post-hoc analysis of the MENSA and the phase 4 MUSCA studies, particularly in relation to comorbid nasal polyposis. Next slide. So the eligibility criteria and endpoints for these studies were rather similar. So adults or adolescents with severe asthma, defined as the need for high-dose inhaled corticosteroids, usually with additional asthma therapy, at least one more additional treatment, which would nearly always be a long-acting beta agonist. So they had severe uncontrolled asthma, as reflected by 2 asthma flare-ups or asthma attacks in the year prior to recruitment. And the presence of nasal polyps and chronic rhinosinusitis was as per the patient history. The endpoints for the DREAM study was the rate of clinically significant exacerbations, and I'm going to focus on the post-hoc analysis related to nasal polyposis, and we'll look at the rate of exacerbations by the presence of nasal polyposis with active and placebo treatment. In the MENSA and MUSCA study, MENSA, the primary outcome was exacerbations of asthma, but in MUSCA, there was a focus more on the change from baseline in the St. George's Respiratory Questionnaire score, so a more quality of life focus. But both studies provided data on the rate of clinically significant exacerbations by nasal polyp status. Next slide. Here are some of the key baseline demographics of the different studies. As is often the case in severe asthma, we have a slight female predominance, a middle-aged population, with about half having adult onset asthma. Patients with severe asthma tend to be a little heavy, so a raised BMI. And a significant number of the patients included in these studies were receiving regular oral corticosteroids because of their asthma. So between 24 and 30%, depending on which study group. Despite a lot of asthma treatment, their eosinophil count was high-ish, at between 250 and 340 cells per microliter. This is the geometric mean eosinophil count, and you can see the duration of asthma was rather similar, and a significant number with adult onset disease. Next slide. The most impactful and the biggest outcome measure, or the biggest clinical impact of treatment, is a reduction in severe exacerbations. And Peter discussed very nicely in the earlier talk how eosinophils might contribute to non-bronchodilator responsive airflow limitation and exacerbations, particularly in relation to mucus plugging of the airways. In the DREAM study, the 3 doses, low, medium, and high, had very equivalent effects on exacerbations. And therefore, the lowest dose, 75 milligrams IV, went forward to the MENSA study, and the findings of the DREAM study were replicated beautifully. So about a 50% reduction in exacerbation, which was also seen with 100 milligrams of subcutaneous mepolizumab given every 4 weeks. So that's the dose that went forward into clinical practice. Clearly a much more practical proposition to give it subcutaneously compared to intravenously. Next slide. A very important feature of the clinical trials I've discussed is that they were able to establish a very close relationship between the effect of mepolizumab on asthma exacerbations and the baseline peripheral blood eosinophil count. And this was seen both in the DREAM study, which is shown in green, and the MENSA study shown in orange. You'll see in untreated patients, as the baseline blood eosinophil count increases, the risks of asthma attacks increases progressively. But that this relationship between biomarker and clinical outcome was completely absent in patients treated with mepolizumab. So as you can see, the benefits of mepolizumab in patients with higher blood eosinophil counts are really very large. Now, we highlight here the point at which exacerbations were reduced by 30%, which many would regard as a clinically important and impactful result of treatment. And this occurred at a baseline blood eosinophil count of 150 cells per microliter. And in many countries around the world, that is a entry requirement for use of mepolizumab. So a blood eosinophil count of above 150 cells per microliter. But the higher the eosinophil count, the bigger the clinical impact of treatment is likely to be on exacerbations. And this close relationship between biomarker and efficacy has really been very important in allowing us to use this treatment effectively and in a way that healthcare payers are comfortable with, because we can be reassured that we're targeting a patient with a high unmet need who is likely to have a big treatment effect. Next slide. Now, I'm going to turn now to a post-hoc analysis where we focus on the effects of mepolizumab in patients who have comorbid nasal polyposis. And the first thing to notice, if you look at the bottom row, is that the proportion of patients that reported nasal polyps was rather lower than anticipated from the data that Peter showed. And this is because, certainly in the DREAM study, there wasn't a very active look for this group of patients. And I think that nearer 30% probably would have reported nasal polyposis or chronic rhinosinusitis if they were asked specifically. But nevertheless, if we look at the population who did self-report nasal polyposis, there were 10% in the DREAM study, and there were 18% in the combined Mensa-Musker data set, meaning that there was a reasonably high number of patients, and they were equally split between placebo and mepolizumab treatment. Next slide. Next slide. So if we look at the left first, you can see at the top the impact of treatment in those who reported nasal polyposis with the 3 doses, low, medium, and high. And at the bottom, you can see the impact of treatment in those who didn't report nasal polyposis at baseline. And what you'll immediately see is that the impact of treatment with mepolizumab, irrespective of the dose, was very much larger in those who reported nasal polyposis. So between an 81 and 71% reduction in exacerbations was seen in this population. A great deal more than was seen in patients without nasal polyps. And if we turn now to the right, it's really a very similar story with the Mensa and Musker population, this time a bigger population of patients with current nasal polyposis, but again, a much bigger impact of treatment, so an 80% reduction in exacerbations in this important subgroup of patients, compared to 49% in patients that didn't self-report nasal polyposis. So no doubt that the presence of comorbid nasal polyposis is associated with a better response to Nepalism treatment. Next slide. And to just show that in terms of numbers and to compare it with the impact of other biologics, you can see an 80% reduction in exacerbation in patients with nasal polyposis in the Mensa and Musker study compared to 49% in those without. But if we look at the QUEST study, this is the phase 3 study of dupilumab, and the focus here is on the higher dose of dupilumab, 300 milligrams every 2 weeks. Again, a bigger impact of biologic treatment in those with nasal polyposis compared to those without nasal polyposis, so 61% versus 40%. And looking now at Relizumab, this is a biologic that targets the IL-4 receptor alpha and therefore prevents interaction between the IL-5 receptor alpha. So it prevents interaction between IL-5 and the IL-5 receptor. A very similar story, so 38% reduction in exacerbations in those without nasal polyps compared to 54% in those with nasal polyps. So this is a very consistent finding. Those with nasal polyps will have a bigger response to biologic treatment, irrespective of which treatment you apply. Please note that these are not head-to-head comparisons. These are different clinical trials with different entry requirements. So some caution is needed in comparing the actual numbers between studies. Next slide. Now, in the Musker study, there was a post hoc analysis of the SNOT-22 score in patients with severe eosinophilic asthma who reported nasal polyposis. And the results are broken down here on the left in those who reported nasal polyps and on the right those that didn't. And you'll see a very big drug effect, so just under 12-point improvement in the SNOT-22 score, which was statistically significant in those with nasal polyps, but also a statistically but less clinically significant improvement in SNOT-22 in those that didn't report nasal polyposis. So certainly in the population that report problems, a clinically important improvement in SNOT-22, which exceeded the minimally clinically important difference by some way. Next slide. Now, another feature of this class of biologics, the anti-IL-5 class, is that they appear to be very safe. So they're taking out an immunological process which has little role in normal healthy living. So IL-5 knockout humans seem to not have any important adverse events. The data from the DREAM, Mensa, and Musker study is summarized here. And I just want to point out that the only adverse event that's been reported more commonly with active treatment compared to placebo is injection site reactions. And we now have long-term safety data out to 5 years and a very big real-world study, the Reality A study, which hasn't identified any other unexpected adverse events. So not only is this a biologic that we can target very well because of predictive biomarkers, but it seems to be a very safe process to inhibit. Next slide. So in summary, Nepalism provides a therapeutic benefit to both the upper and lower airways by reducing significant exacerbations and by improving nasal polyposis and chronic rhinosinusitis status in patients. It does so by binding and inactivating IL-5 and thereby reducing blood eosinophils to very low levels. And you've seen in a post hoc analysis of 3 phase 2 and phase 3 studies, Nepalisumab reduced clinically significant exacerbations in patients with severe eosinophilic regardless of nasal polyposis status, but the benefits of treatment seem to be much larger in those that reported nasal polyposis than those that don't. And patient-reported SNOT-22 status was also improved to well beyond the clinically important difference in patients with severe eosinophilic asthma who reported nasal polyposis. Thank you very much. And next slide.
Excellent lectures. It was really, for me, very informative. And I will open the discussion with a dominant question, okay, which is the relevance of the upper and lower airway diseases to the patient outcomes in the eosinophilic inflammation. Peter?
Well, I think
you.
I think probably what I've demonstrated is that eosinophils are an important risk factor for what's going to happen to the patient. That in the lower airways, they're more likely to have an exacerbation, they're more likely to have worse control, they're more likely to end up with worse lung function. And in the upper airways, one can see a similar process, that eosinophils are a risk factor for recurrence of polyps, or so a risk factor for development of polyps. And the same pathological process will be ongoing at that site.
Ian?
Yeah, I agree. And clearly the presence of nasal polyposis is associated with a better clinical response through anti-IL-5, not only in terms of the lower airway response, but also the upper airway response as reflected by the SNOT-22. So certainly, clinical practice in the severe asthma clinic has changed very significantly in the last 10 to 15 years, but one of the key changes is that we've become very interested in nasal polyposis, and many of us have established very close working relations with our ENT colleagues. So we in Oxford run a joint clinic, and of course it's exciting for both of us, for both the ENT colleagues and for us, to have new options for these patients, because they were tough patients to look after in the pre-biologic age. Although many did very well with oral prednisolone in the short term, they accumulated side effects fairly rapidly, and that was not a sustainable long-term treatment for many of my patients.
So Ian, I was reflecting when you were presenting about the prevalence of nasal polyps in the DREAM and menstrual muscular studies. I said 25% of those patients were on maintenance oral steroids. And so that may have lessened the appreciation of nasal polyps. But the use of maintenance oral steroids, as you mentioned, is now substantially reduced with the availability of biologics.
I think that's a very strong possibility. And of course, oral corticosteroids are fairly effective at reducing polyp size, and they're often very resistant to topical steroids in my, at least in my clinic. But I think the problem with DREAM and Mensa to some extent is we didn't systematically ask about nasal polyps. I think we could have done a better job of getting that history. And all ongoing studies will certainly do a better job.
So I think for us as rhinologists, and we learned a lot from you, from respiratory medicine experts, from pulmonologists, allergologists, one question that arises consistently the last months, let's say, is which is the right patient for a monoclonal antibody therapy? Because in order to optimize the therapy, in order to optimize and reduce the therapy failures, and to optimize also health costs. So what is your statement? Which is the right patient? Of course, we need studies to evaluate this question, but I would like to ask you.
Shall I start?
Yeah, go on.
Yes.
Go on, Ian.
So, two things really to look out for. One is the blood eosinophil count, and I would make that part of your standard clinical assessment when you see patients with polyps. So, the higher that is, the higher the risk that the patient will have asthma attacks, and the higher the likelihood that they'll respond to biologics. So that's a very important thing, and often in patients you see in clinic, there's plenty of blood eosinophil counts in the medical record. So do just have a look at those. The second feature that's really related to efficacy of biologics is frequent exacerbation. So ask the patient how often they've had a course of prednisolone in the last year. And I also ask, well, how do you feel when you're on prednisolone? And if the patient says, I feel great, my nose is clear, I can smell, I can breathe, that patient is likely to do well with biologics. So those are the patients to look out for. I don't know what you feel, Peter.
I think the last point you make, and is one that probably hasn't been formally studied, certainly not in the upper airways, that if you take an individual who says, I get better when you give me oral steroids, but I get worse when you stop them, and we know that oral steroids are really focusing on eosinophilic processes, whether that is a patient who would do very well from the upper airway perspective.
Okay.
We know from the lower airways, as Ian said, that when we take individuals with recurrent exacerbations, which are individuals who are receiving recurrent courses of oral steroids, they are a type of patient who will do well on a biologic. And so I think that could be translated into the upper airways, but it would need some form of assessment to prove that.
And we made as rhinologists also the experience that if we have a patient with nasal polyps and he has also bronchial asthma, and we perform an polypectomy, removal of the polyps and a drainage and pneumatization of the sinuses, then he will improve after surgery. And the question for us that arises consistently is, what is the right timing to go for a monoclonal antibody therapy? And I think this is also something that we have to evaluate with studies. But Ian, what is your feeling? What is your opinion about that? Do you think that we can solve the problem in the future only with conservative therapy, or should we go first for surgery and then add?
I mean, I am straying outside my area of expertise, and I think.
But I think this is an important question.
But from discussions I've had with Ian knows and both colleagues, and the last few years I've got to know, and I've had some very interesting conversations. I think that surgery and biologics target different aspects of the problem. So one of my surgical colleagues mentioned that the surgery is very good at dealing with structural issues and drainage issues. And he said that it worked much better and the results were much better if you got rid of acute inflammation, either by giving prednisolone or a biologic. So they're complementary in many respects. That would be my view.
Yes. Yes.
But that they target slightly different aspects of a complex problem. So surgery, anatomical deformity, better drainage of the sinuses, biologic treatment, best, treatment of acute inflammation, edema, and other aspects. So I think you're not out of a job, Yanis. In fact.
So Peter, your statement?
I agree. I think they're complementary. I was reflecting on the fact you said that when you operate, the asthma also may get better. And really what you're doing is reducing the magnitude of type 2 inflammation by taking away all that tissue. But the disease comes back. Yes, so it's not dealing with the underlying problem. And I think that's where the biologics come in as a therapy to try and control that underlying disease process.
Yes.
And so, at the moment with the trials that we've had, we've taken the worst patients, which one often does with a new therapy, to see does it improve. But I think as we move forward, we probably need studies to try and understand if you use them earlier as a complementary treatment with surgery, would that prevent worse disease happening in the future.
Okay. Did we have questions from the audience? Feel free to ask our experts because we have really distinguished speakers.
I have one question.
Yes? Hey, you, Anastasia?
How many years the treatment lasts?
How many?
Years. Right, now it's an important question, and it's one that we've tried to address. That there was a study called the COMET study, which took patients who'd been on Nepalisumab for 3 years at least, and then in a randomized, double-blind, double-dummy approach, stopped some patients and carried on treatment in other patients. Neither the physician or the patients knew which injections they were having, so some went on to placebo, some went on to Nepalisumab, and what that showed that within about 12 to 16 weeks of stopping, blood eosinophils went up and patients started to exacerbate and their symptom control decreased. So we are thinking of this as a long-term treatment, and that's where the safety aspects that Ian brought in are very important.
Ian?
Yes, no, that's the biology comes back usually within 3 months and the clinical problem follows soon after. That would be my experience with stopping the anti-IL-5 class of treatments. And we don't have good information on drugs other than Nepalisumab actually, but there's no particular reason to suppose it would be different with the other classes of biologics. So yeah, we know surprisingly little about stopping other biologics.
There is another question?
Yes. Which of the monoclonal antibodies are approved in Europe and what would be suitable to start a treatment? And the next question was for how long and how often should be prescribed for the patient? And the forms are only IV or there are another forms that can be carried out?
Peter?
Well, I think as you mentioned, at the moment, we've mentioned about Nepalisumab for severe asthma, but it's not licensed for upper airways disease. So the treatment where you've seen improvement
In Greece, we are waiting in the beginning of 2022 to have the license to use the...
So in Europe, Dupilumab and Omalizumab are licensed for nasal polyps.
Yes, Anastasia?
I have a question.
Louder?
If a patient has also nasal polyps and asthma, would you recommend the first surgery and after starting the biological agent? Or would you recommend to start the treatment, the conservative treatment, and afterwards evaluating again?
Yes, this is what we said before, the timing of a monoclonal antibody. We didn't have clear results from studies, but the feeling is, as I said, clinical experience. This is a feeling, this is not proved, okay? Therefore we need studies. That if you remove the polyps and if you drainage the paranasal, the nose and the paranasal sinuses, then these patients have an improvement of the clinical course, but not for a long time. Let's say for 6 months, 1 year, and after the polyps relapse, you have a recurrence of the polyposis, and therefore we need studies to evaluate us.
Another question. If a patient is in another treatment with another biological, how long would you wait?
I cannot answer, Anastasia.
No. There has been a study in asthma on patients who are on Omalizumab and was switched to Nepalisumab, and it was switched either 2 weeks after the last Omalizumab dose or 4 weeks after, depending on what treatment regime the patient was on. So I don't think there is any need for a washout or any sort of caution from that point of view.
Ian, do you have some statement before Peter give us the closing remarks?
No, I mean I haven't been able to hear the questions from the floor very well, but yeah. So in terms of switching, I don't wash out drug A before switching to drug B. I don't see a good rationale for doing that.
Okay.
We just schedule their next injection to be the new drug. Yeah. I think there is scope for further work and risk factors for recurrence of nasal polyposis after surgery. I think it would be good to have a better understanding. We know aspirin sensitivity tends to be a group of patients that do badly. They're very, very eosinophilic, that group of patients usually. And another point just before we finish is that you guys, Ian knows from hope specialists, are in a really good position to identify these people and to send them to a pulmonologist, because I get a lot of referrals from my colleagues, Ian knows from hope, because they're seeing a lot of these patients. So do look out for them. There are new treatment options, and the treatment that we, the pulmonologists, will apply will likely help with the problem you're seeing them for as well.
Yes.
So do look out for them and do send them along.
Yes, you are absolutely right.
Yeah.
We have learned a lot from you, and therefore we collaborate excellent with our pulmonologist, and we run together a medical thesis, and this is something special for us because we learned really a lot from you, and we are not experts in respiratory medicine, and I think the best results if we continue to collaborate in the future. And thank you very much, Professor Pavord, for being with us.
I wish I could be with you, actually, but hopefully...
maybe in the future, in the next time.
Thessaloniki in September sounds lovely to me.
Okay. Thank you so much. And please, Peter, give us the closing remarks.
Yes, very briefly. Yanis, thank you very much for driving that discussion. I think that was extremely valuable and helpful. And I think that as we move forward, it is partnership between pulmonologists, between ENT surgeons and with patients, all working together to get the best outcomes. But what we've heard today is that those patients with severe eosinophilic asthma often have comorbid nasal polyps, that there is a common pathology with eosinophilic inflammation, and we've talked about the crucial role for interleukin-5 in that eosinophil-driven process. And we've heard from Professor Pavord how targeting IL-5 with Nepalism leads to improved outcomes, not only within the lower airways in patients with severe eosinophilic asthma, but in the upper airways in those patients if they have coexistent nasal polyps with improvements in their SNOT-22 score. And so I appreciate that your focus, as we've heard from the discussion, will be on the upper airways, and what we've identified is that there is more studies required, more information needed. And I just end with the safety data as far as Nepalism is concerned. And thank you all for attending today and listening in, and I've enjoyed it very much, and I hope you have as well. Thank you.
So I will close the session, and I will promise you that this was only the beginning, let's say. So this is a movie that we will say the second part, and maybe the third and the fourth. Okay. Thank you very much to the GSK company for giving us the opportunity to share this knowledge in our meeting here in the ERS meeting 2021. And I hope we will go hand in hand in the future together. Thank you very much.